Good morning, everybody. I feel delighted to explain to my fraternity of pharmacologists regarding a less trodden path. Many of my colleagues told me that this is an alternate career option, but I have a feeling that as medical pharmacologists, we must stay as close to patient care as possible. And that does not mean to undermine our presence in academia or industry. Though our peers are doing well in academics and industry, most doctors are not aware of the role of a medical pharmacologist in patient care. It is at least not as obvious as an orthopedician who sees patients with complaints regarding the bone, or an ophthalmologist who sees patients with complaints regarding the eye. And for this same reason, I thank the CME Council members of Medical Pharmacologists Society for inviting me to share my experience over this webinar as a hospital-based pharmacology consultant. I'm Dr. Jerin Jose Cherian, and I currently work in Rajgiri Hospital in lush green Kerala. To give you some perspective, ours is a 500-bedded multi-specialty hospital with nearly all specialty. We have over 2,000 inpatient days in a month and an equal number of outpatients every day. This is an NABH and JCI accredited organization. After a very brief stint in academics, I joined this place as a consultant in the Department of Clinical Pharmacology. And people here know that if you have a broken bone, you need to see an orthopedic specialist. If you're pregnant, you need to see an obstetrician. So I often got asked, you are a doctor and you work in a hospital, which is not a medical college. So what do you do? Since this is a relatively new field with very few people opting for this career, I find it difficult to explain to people what I do. At the very outset, I would like to tell you that every day I'm learning of new possibilities, and I don't consider myself an expert in this field. I'm here to share with you my humble experience. So that's what I will try and do in the next 30 minutes. I will take you through my presentation after the disclaimer that is customary. That contents used are not copyright protected, meant for educational purposes only, and that my views are my own and are not representative of any other. A quick overlook of the presentation. First, we will go through a few slides detailing the harm caused by medicines, the definitions, classifications, global burden of the problem, etc., followed by some aspects of medication safety, including the current WHO Global Patient Safety Challenge, that is, medication without harm. Finally, how a clinical pharmacologist's role is vital in a hospital and what impact has my organization seen through the interventions of my team. This is none other than the famous Canadian physician William Osler, and this quote of his is very relevant since humans are perhaps the only species which rely on medicines for prevention and cure of diseases. And we all know that medicines are not devoid of noxious effects. Now, noxious or unintentional effects are just one of the aspects that could go wrong while taking medicines. One of the ways how most schools classify medication error or medication-related harm, is 1 as medication error and 2 as adverse drug event. There are some societies that think medication error is a subset of adverse drug events or vice versa, but the World Health Organization handles them both as distinct entities. Lisby and her colleagues conducted a systematic review of the operational definitions for medication errors, and there were about 26 different terminologies that were used as synonyms for the term medication error. This reflects the non-harmonized ways in which this problem is addressed on an international level. Just the same way as with the terminologies, there are also a broad range of definitions. So let's have an understanding of the working definitions. The NCCMERP is a 20-year-old American council that works on medication error detection and prevention. A medication error is defined by the NCCMERP as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or the consumer. The WHO cites this definition used by NCCMERP as well. Since the term medication error has got a negative connotation associated with it in my institution, we prefer to use the term medication safety breach rather than medication error, which essentially means the same, just that it is devoid of the negative connotation associated with the word error. Now, adverse drug events, we all know, is any noxious or unintended event associated with the intake of medicines. Let me also introduce you to 3 other terminologies relevant in this context: near misses, incidents, and sentinel events. Near misses are those errors that occurred but were not significant enough to cause harm or were intercepted before it reached the patient. Now, incidents are those errors that reach the patient, while sentinel events are those serious errors that reach the patient. I guess everything else on the slide is self-explanatory. Now, this is a reproduction of the results published in a study where perioperative medication errors and adverse drug events were analyzed. Medication errors and adverse drug events were almost equal in number. However, the most notable difference is that While more than half of the ADEs were preventable, all of the medication errors were preventable. Also, a huge proportion of the medication errors resulted in moderate to severe harm to the patient. During the past decade, we have witnessed an alarming rate of medical mishaps all around the world, including from India. While there could be many explanations for this, one definite reason is that healthcare is getting increasingly complex and have high risk work environments. We have branched out to specialists and super specialists who deal with narrower and narrower disease spectrums. We have a vast number of new medicines that are being developed by various companies regarding which healthcare workers need to be updated about. Patients are more and more conscious regarding their health, and healthcare institutions are having to cater to an ever increasing load of patient inflow. Now, to allow you to understand the gravity of the problem, let's go through some of the studies that have tried to measure the burden of medication errors. Global economic burden of medication errors was estimated by the WHO at a staggering 42 billion US dollars. To give you some perspective on that, 42 billion US dollars is more than 5 times the 2017 Indian healthcare budget. Now, 12% of all primary care patients in the UK will be affected with a prescription error. This was especially so when patients were more than 75 years of age or they had more than 5 concurrent medications. A study done in Mexico showed that 58% of the prescriptions had errors of some sort or the other. Most of them were dosage regimen-related errors. A new standard was developed to measure the economic burden of patients requiring readmission in a hospital with a medication error. And this was called HARM, H-A-R-M, abbreviation for hospital admission related to medications. And this study done in Netherlands estimated that around 6,000 euros was spent for each patient following admission related to a potentially preventable medication-related injury. Now, there are so many such examples in literature, and unsurprisingly though, there aren't many studies from India. And I guess it's only because of underreporting. Now, I've provided the references of all of these on the same slide. Since this is due to scientific development, all this is due to scientific development, the complex nature of these systems are progressive and unavoidable. Hence, we must admit that healthcare is getting increasingly complex. The complexity is following a pattern as of the Moore's law in electronics. Gordon Moore, the co-founder of Intel, predicted that with ongoing R&D in microprocessor technology, we will soon reach a technological advancement that would be of minimal significance. It is basically the same as a slippery slope phenomenon, only thing the slope is upwards. The Moore's law has ever since been translated into various industries, including economics, aerospace engineering, and telecommunications. Now, how does that translate to the healthcare sector? With the scientific and technological progress in healthcare, the systems are getting inevitably complex. And this is exponentially increasing the risk within the healthcare system. There's a lot of research that points to system improvement in healthcare organizations as the answer to this burgeoning problem. And that is what national and international accreditation bodies are paying attention to. If you look at it, the reasons for medication errors are not too many. From all the literature references that I provided below, knowledge and caution deficiency is often proposed as the most important reason for medication errors. Right from the person transporting the medicines from the vendor to the hospital, up till the nurse administering the medicines to the patient, a deficiency of knowledge or skill or caution could all lead to error. The next most important reason is the lack of a systematic way of detecting and reporting errors. Like Carl Pearson said, only that which can be measured can be improved. Unless we measure the trend of medication errors in our hospital, we will never know where we stand and what steps to take to improve. Complex medication regimens that are difficult to untrained pharmacists, nurses, or junior doctors is definitely a problem. And an inadequate medication reconciliation or review at every change of level of care is another reason proposed by various authors. Distractions, interruption of medication-related activities, work time pressure, and the use of high-risk medicines are also assumed to be reasons that lead to medication error. Now, various international agencies and governmental bodies have identified these risks. Many have come up with plans as well, including the WHO, the ISMP, which is the Institute for Safe Medicine Practices, the US FDA, the American Hospital Association, etc. In India, these activities are coordinated by the WHO under the aegis of the Quality Council of India, the details of which can be obtained from the links provided. Now, of particular importance is the risk mitigation strategy campaign introduced by WHO. Understanding the gravity of the situation, WHO has launched the third Global Patient Safety Challenge in March this year. The goal of this challenge is to reduce medication errors by 50% in the next 5 years. So there's a global campaign that will be initiated soon in alignment to the WHO goals. India, as a member state of the UN, is most likely to implement this through the National Healthcare Quality Body, that is NABH. As member of the Global Patient Safety Network, I have been very fortunate to be associated with WHO in the third Global Patient Safety Challenge. This is a screenshot of the webpage, and for those of you interested in learning about the project, I have put in links to the relevant documents from WHO and Lancet. Now let's try and understand the flow of medication in a hospital. Excuse the animation. It should have started from selection, gone all the way through procurement, storage, prescription, transcription, all the way to monitoring. The direction was wrong. So a drug is selected to be purchased, procured from the distributor, stored within the hospital, and from here it moves to various pharmacies as per the requirement. Upon prescription, a transcript or an indent is raised to the pharmacy. The prescribed medicines are checked and dispensed. It is prepared for administration, labeled whenever appropriate, and then administered. Certain medicines, such as insulin, require monitoring after administration. And now this cycle is complete, since the feedback from any of these stages will further help in selecting a new drug when it has to be procured. Now, as doctors, we often do not pay much attention to this medication management process, but understanding this process is crucial to understanding why and where each medication error happened. We could go to any extent of putting in place various check mechanisms at any or all of these levels to ensure that safe medication management is practiced in our respective institutions. Now, as a clinical pharmacologist in a hospital, we can do a lot to prevent medication-related harm. The first hat that I wear is that of a medication safety officer, and so any inadvertent medication error that is identified is reported to me. There is a passive surveillance of all medication errors other than prescription errors. It works well. This system will work well only in those places where a just culture is in place for handling such reported errors. The medication safety officer interviews the concerned staff to ensure a thorough root cause analysis is done and appropriate corrective and preventive measures taken. If the error is of a serious nature, it is communicated to the patient by a multidisciplinary team involving the clinical pharmacologist and the nurse and the treating physician, at least. All errors that are detected are recorded and discussed in a weekly safety meeting. The multidisciplinary team is also accompanied by a professional counselor if needed. These errors are always handled in an anonymous fashion so that the details of the doctor and the details of the patient are blinded. Apart from this, an active medication tracer is conducted every quarterly to audit the entire cycle of medication management. The commonest medication errors are prescription errors from all the literature that I've come across. And hence, a thorough prescription audit is done by a team of clinical pharmacists for each and every IP and OP prescription. In my hospital, we have 2 levels of checks by clinical pharmacists in all non-critical care areas before every medication is intended to the pharmacy. While in critical care and oncology settings, we have a dedicated clinical pharmacist who accompanies the doctor on rounds. Prescription errors that are detected and reported immediately if corrections are necessary. This real-time audit feedback loop is perhaps the most important step in medication error reduction. This strategy is endorsed by various healthcare accrediting and quality bodies. Other activities of medication safety include pharmacovigilance. Our hospital has been declared an area monitoring center by the Pharmacovigilance Program of India, and we report such events to the database maintained by Uppsala Monitoring Center. Another important role of the clinical pharmacologist is in ensuring the rational use of medicines, and especially antibiotics. The development and implementation of a hospital-specific antibiotic policy based on local antibiogram is the starting step. We also present antibiotic consumption data, provide consultations on the choice of antibiotics in difficult scenarios, and conduct compliance audits to the antibiotic policy. By working in close coordination with various departments, such as nursing, quality, pharmacy, infection control, and drug purchase, we can leverage a wider impact. Another often understated intervention is by providing cost-effectiveness interventions and making healthcare affordable to patients. Continuous in-house training for doctors and nurses, both during induction as well as at periodic intervals, is another thing that clinical pharmacologists can engage in. We also have medication educational activities carried out by clinical pharmacists in special high-risk scenarios such as with oral anticoagulants, elderly patients on multiple medications, and even oncology patients. Apart from this, the department also runs a 24/7 drug information center whose quality of service is monitored every month. Other areas that can be handled by a hospital-based pharmacologist are clinical research, pharmacogenetics, therapeutic drug monitoring, kinetic consultations, etc. Since these domains warrant a separate presentation each, I'll leave it for the expert in these respective fields to handle them. I'm sure that there could be more things that can be done on which I'm willing to take suggestions. All right, now it is the time for me to show you the impact of our interventions in my hospital. We had a major process change implemented in September to October 2016. We introduced the medication room concept in our hospital during this period. They were designated access controlled, thermo-hygro controlled, clean environments with all ergonomic infection control precautions taken. These were specially designed spaces to handle every aspect of medication management. Before the implementation, the pre-implementation phase had an average incidence of medication errors of 6.62, and during the post-implementation phase, this reduced to 2.56%. There was an overall 38% reduction in medication errors. And here you can see the differences in the near misses and the actual incidents that happened before and after the intervention, after the medication rooms were put in place. For confidentiality reasons, I have not displayed the exact number of each error. Now you can see that after the medication rooms were put in place, there was a drastic drop in both the near misses as well as the incidence of errors. Now we conducted a survey of the nurses and doctors to know what they felt about our intervention. And this is the nurses' response. 94.5% of the respondents mentioned that our interventions reduced their workload. Other aspects appreciated were risk reduction strategies implemented and the drug information services. An average work reduction of 63.7% and risk reduction of 53.5% was obtained from feedback from the nurses. We have also received a lot of positive feedback from the physicians, which is clearly indicated by a 94% of acceptance of the clinical pharmacist interventions. Apart from the routine activities, we are involved with some other departments such as neurology, infection control, oncology, and critical care, provide specialized services in their respective departments. Now, to conclude, a hospital-based pharmacology consultant is a vital link for institutions that wants to uplift their medication management processes. This can serve as an ideal liaison officer among administrators, physicians, and healthcare quality team. With this new global patient safety challenge launched by WHO, I'm sure that there will be requirements in many healthcare institutions for skilled personnel in the medication safety domain. For those of you who are curious and would like to learn further, we have internship programs to which you could apply. I've also put in some links from various universities abroad where they provide master's or postgraduate diploma or PhD programs in certain aspects, such as the King's College London, University of Cape Town, British Society of Antimicrobial Chemotherapy, BSACs, and the Karolinska Institute. So that's Nani in Malayalam, my local language, and a whole lot of thank you to everyone who stayed until the end. I would like to please and record my acknowledgement to the team at MPS for steering this webinar. I would also like to thank my institution for providing me with all the necessary support, which is mandated in this nascent field. Now I could either take a few questions or I would be delighted to hear your comments. You could also drop me comments or questions on the email address provided below.